Our next speaker is Jaime Hernandez-Montfort, talking about PVR and pulmonary arterial compliance in assessing pulmonary hypertension.
Thank you. Thank you for the invitation. It's always amazing to see how the conference is growing, the community is growing as well. And I think it was a challenging question. I felt originally like Michael Scott's quote. But we'll try our best. I think what we have definitely understood better is that there has been an evolution of our hemodynamic understandings. We're just not talking about volume and peripheral circulation anymore. We have, profile patients between right heart, left heart, biventricular profiles, and we have included the pulmonary vasculature in our assessments. Of course, we're going to talk about here of cardiac shock, and I want to make a deep dive in our day-to-day practice, which is heart failure cardiac shock. And we know that there's a complex pathophysiology that definitely impacts our transitions, our decision-making, and a component of pulmonary and right ventricular to pulmonary artery coupling that involves a lot of our decisions to transition patients to heart recovery, and specifically from a heart replacement standpoint to durable LVAD versus transplant. And I think a lot of our decisions when we are dealing with heart failure cardiac shock is really trying to determine the status of the right heart, knowing that from a historical or retrospective data from our first analysis in the shock working group, the bilateral profiles or the right heart predominant profiles in cardiac shock were associated with an increased mortality, advanced SCAI stages. And when we think about the right heart, there's many avenues that we can definitely focus on, but for purposes of today's talk, we'll talk about pulmonary vascular resistance, pulmonary arterial compliance. Definitely, many of these patients will have to start their road to determine the next best steps in biventricular support or high-profile support. And starting with a hemodynamic definition of right heart predominant cardiac shock, we incorporate right atrial pressure, RA pressure with wedge ratio, pulmonary artery pulsatility index, which was predominantly platformed by the investigators at Tufts and then by cardiac shock working group, and as well right ventricular stroke work index. But really, the incorporation here, or incorporating pulmonary vascular resistance or pulmonary arterial compliance, hasn't really been mainstream. We know, of course, that the right heart has many etiologies, and the hemodynamic impact really depends on what we're trying to obtain. In this context, we're going to focus on the afterload of the right heart based on the pulmonary vasculature. And I think here is where the role of pulmonary arterial compliance comes into play. I really like this couple of recent articles that try to differentiate acute elevations in pulmonary capillary wedge pressure or left atrial pressure, trying to discern the impact of acute insults versus chronic insults, and how the decrease in the pulmonary arterial compliance then leads to increased pulmonary vascular resistance, particularly in these patients with chronic systolic heart failure that end up exuding cardiac shock. So in this context, also there's another recent article that is in preprint basically, but the images are available and the full manuscript is available, in which they basically divide the interfaces. And when I look at this is really a nice schematic in which basically our day in the office can coexist with actually clear targets of our therapies. So now in a lot of these patients that will end up mechanical support, we're trying to connect with the interface 1, which is the left ventricle to systemic arterial coupling, and then see what is their response to interface 4, which will be in this case the right ventricle to pulmonary arterial coupling. So this is not a new concept in cardiac shock. Dr. Tedford and his team and many others that have done amazing work in the understanding of the right heart after durable LVAD, one of them is Dr. Estep that is here, has really identified this hemodynamic signature of right ventricular afterload sensitivity, what we will call right heart load surrogates, which is Again, the right atrial to pulmonary capillary wedge ratio, or going beyond that with pulmonary vascular resistance, pulmonary vascular elastance, and pulmonary arterial compliance, which you can see they're all affected by LV unloading. When we try to translate this in our day-to-day practice among those patients that receive perhaps a higher profile transvalvular pump devices to decrease LV pressures and improve volume, we find that Impella 5.5 has been widely studied. In retrospective analysis, only in an association has been noted that is associated with decreased mortality and with an improvement in their transitions with heart replacement therapies. So in this particular context, when we use the Impella alone versus other devices, we see a signal or an association towards benefit. So we have been using transitioning based on the concepts of trying to normalize hemodynamics as much as we can, temporary mechanical support in the form of transvalvular pumps to try to decrease all these right heart load surrogates, and ideally find this matching concept of hemodynamics pre and post that are close or as close as possible to each other. In this case, that you can see normal RA pressure, normal pulmonary pressures that are almost mimicking the same amount of flow on 5.5 and on HeartMate 3. And that is what's pretty much happening in sort of our practice in Temple, in which again we see patients that are extremely sick, coming in with very high advanced SCAI stages, phenotypes 3, very sick patients with very high loading conditions by ventricular failure, and we're using the device to assess responsiveness of the right heart in this particular case. As noted, there's not only a device that is in place, but the goals of the therapies that have been described before, such as decongestion, like in this particular case, 30 kilograms later. I think we have found that the right side of the heart has coupled with the pulmonary circulation. So in this context, as we know better about the integration of clinical hemodynamic and imaging for shock profiles and transitions, definitely there's an opportunity for incorporating the right side hemodynamics into our understanding of such transitions. I think there's still a lot of work to be done in this space. The right heart afterload surrogates in heart failure cardiac shock, particularly on the responsiveness or the need for escalation from these patients from low profile support to high profile transvalvular pumps to ECMO is needed. And this is a nice example for Joy's team, in which they basically were able to longitudinally for the first 14 days start connecting these surrogates of pulmonary artery diastolic pressure and estimated right ventricular afterload by different time points, as you can see in this very nice paper that was recently published. So in conclusion, I think we should start having a common hemodynamic language when we round, as we have critical care cardiologists, intensivists, heart failure specialists, surgeons, in which we talk about pump function or optimization of pump function, optimization of tissue perfusion, reducing the metabolic needs of the patients, but also assess the longitudinal right heart load in the same context. And with that, I think we want to avoid these advanced stages. We really want to refer early so we don't have to start in the really bad biventricular profile that we just showed. Thank you very much.
Okay. Thanks for a really comprehensive review of the subject. So the question is PVR versus pulmonary arterial compliance. And, I've never really trusted PVR. I've used it all the time, just like everybody else in the room. It's easy to calculate. We certainly incorporate it into decision-making with regard to cardiac transplant candidacy. But I wonder whether we're missing something, since it really is not truly a physical characteristic of the vasculature. It's a made-up number. We're dealing with a pulsatile circuit, so that resistance doesn't actually mean anything from physical terms. Pulmonary vascular compliance, on the other hand, I think of as an actual physical property of the vasculature. And I just wonder whether that should lead us to sort of go from one end to the other and start looking at pulmonary compliance more?
Yeah, so as you mentioned, we're really looking at the pulsatility of the pulmonary artery and connected with the stroke volume. And I think, as Dr. Hayward's recent paper is alluding to, is probably that's a more direct surrogate or more physiological, as you mentioned. And, you know, I mean, it makes me think of a lot of decisions that we have made for specific patients for determining their candidacy for transplant and whatnot, in which we have not resolved that primary issue with, which is high left atrial pressures. A lot of the things that we're doing right now with pulmonary arterial compliance is, as Joyce's paper really measured them longitudinally. And to be honest, from at the bedside, what we really looked at is to see, after we put patients on biventricular shock, on support, how's the pulsatility of the PA looking, and we see that pulsatility improving. We know that those patients are probably heading in the right direction of univentricular failure, and the windows of opportunity for transitioning for specific replacements open for both options.
We have a little time if other people have questions or comments on the
I guess just for me, and I think maybe the panel as well, I think when we deal with these patients with biventricular support, I mean, when you have, for example, a centromag, which is tunneling in tons of volume, 4 liters, how much ever it may be through the pulmonary artery, what measures should we be using? I mean, what is our goal to say, oh, this seems like something that's recovering? Because echocardiographically, significant limitations, whatever parameter you may use, and ultimately you're stuck with mixed venous and CVP levels, and at that point, how much of the catheter is playing a role in getting false numbers? So I don't know what your experience has been, or for the panel for that matter, as to how to guide ourselves when we put these patients on BiVAD.
Yeah, so BiVAD centromag certainly is a challenge by imaging, and I think we will still use a PA catheter, and perhaps, again, once the lungs are completely clean, the patient is decongested, and organ function has resolved, really using, you know, surrogates of, you know, pulsatility, mixed venous, and start to wean off the right side of the heart device if your intention is to open the possibilities. Again, that cohort is high risk in my view, since, again, a lot of potential complications can occur if you don't transition them in a reasonable time frame. But certainly it is that you will not have the same echo surrogates that you will have with other temporary devices when you are on centromag BiVAD. But I know Jerry will.
So no, I think it's a great comment and subsequent comment in that it begs the question, what are we using these hemodynamic parameters for, why, and when? And for, you know, PVR versus pulmonary artery compliance, you know, in terms of as a therapeutic target or a prognosticator, or to guide decision-making in terms of stabilization, wean, readiness, or thereafter. In your centromag case example, you know, I would say I'm not using either, and you're going to understand stability by mean blood pressure, maybe CVP, and then as you decide to wean, you're going to understand that metabolic profile change and blood pressure change, and certainly, you know, PVR or PAC is going to be helpful, but they're a little bit lower in the prioritization, at least for us, in terms of clinical decision making. And so you know, the pulmonary artery compliance story, I think, is gaining some ground compared to the classic PVR, which is influenced by how you're measuring output. And I too, you know, we calculate it all the time, but I'm looking at the transpulmonary gradient, to be quite candid, more in terms of decision making, even in the pre-transplant patient population. So I think the jury is not out yet on where PAC will be versus PVR, but I would say it's beyond those two numbers alone would be my take-home message.
Yeah, I think I agree with Dr. Constam here. We're talking about two variables. One is the PA systolic, which is dependent on the RV generation of the pressure. And the second, which you're looking at, is the cardiac output. So the denominator is already a variable and the numerator is variable. So I don't really think PVR is a good estimate. I think capacitance is a better estimate. In regards to the pressures, if you're having a centromag with the flow coming into the PA, I'm not very sure what a PA catheter number means in those numbers. And in Jerry's question, I think a crude measurement is blood pressure, but that's too late a variable Only when the right ventricle is really, really bad, you're going to have a low blood pressure, but you can still have a limping right ventricle, which will not do well after a week or so. So I don't think we have a good, precise way of trying to wean. So.
Yeah, I think it's a good point, but one has to put it in context with the question at hand. If you've defined a stable patient and you want to do a wean, my eye in the context of an RV reserve is going to the pulmonary artery pulse pressure, right, the pulsatility, CVP, and subtle changes in mean blood pressure with ramp down testing, right, and then durations of testing. So in other words, I'm with you in that it's specific, but perhaps too late, but it's part of the algorithm in terms of even understanding to do and commit to a real wean trial. So I think it's, because if you fell that at the bedside with a simple ramp down, there's no reason to do a longer duration, right? You answered the question. So that's why I think it is specific. Blood pressure, effective flow pressure is important. But I think we're saying the same thing in the context of the importance of PAC. It's just not something we've readily have messaged in bedside rounds as much as it deserves, perhaps.
Yeah, we struggle with the same concept when we have people on Protect Duo or some spectrum cannula connected with a CentriMag, and whether we still need a PA catheter. But it is helpful once you're weaning down to start seeing that pulsatility. At least, again, there's a lot of work to do in the field for sure. Thank you.
Thank you, Jamie. The next speaker is Dr.